Hypocalcemia, primary hypoparathyroidism, is most often a complication of pure neck surgery, such as orthorectomy, if the parathyroids have been removed. Other causes are hypomagnesemia. Magnesium necessary for parathyroid hormone to be released from the gland. Low magnesium will lead to increased urinary loss of calcium. Renal failure which leads to hypercalcemia. The kidneys convert 25-hydroxy-D to the more active 1,25-hydroxy-D. Vitamin D deficiency, which can be caused by inadequate sunlight exposure or insufficient intake. Unlike hypoparathyroidism, vitamin D deficiency has low phosphate and elevated alkaline phosphatase. Parathyroid PTH is elevated because calcium is low. Choose 25-hydroxyvitamin D as the best test of vitamin D level. Deficiency causes rickets, childhood disease of impaired long bone growth, and craniotabes of soft skull bones. Accumulation, adult disease of bone impairment, milder than rickets, and muscle pain. Now, genetic disorders, fat malabsorption, dual improvement state. For every 1 point decrease in albumin, calcium levels decrease by 0.8. Is not symptomatic, hypercalcemia, and no calcium replacement is needed. Cow's milk has significant vitamin D only because it is added. The fruit with the highest naturally occurring level of vitamin D is salma. Signs of neural hyperexcitability in hypocalcemia. 06 sign present nerve hyperexcitability, calcopedal spasm, perioral numbness, mental irritability, seizures, and tetany, trausucine. Low calcium causes twitchy and hyperexcitable. Hypercalcium is lethargic and slow. Testing is EKG, which shows a prolonged QT that may eventually cause arrhythmia. Third life exam shows early cataracts. Treatment is calcium replacement and activated vitamin D. It is given orally if symptoms are mild such absent and intravenously if symptoms are severe. Various disease of the bone. In Vegas disease, osteoclast and osteoblasts work out of sync, deforming the bone. Vegas disease of bone can become osteosarcoma. Most patients are asymptomatic, and a range in alkaline phosphatase is found, accompanied by normal gamma-glutamyl transproperatase (GGTP) and normal bilirubin. Abnormalities are found on scalar survey. In symptomatic disease, the most common symptom is bone pain. Diagnosis testing includes nuclear technetium bone scan finding patchy areas of osteoblastic activity, most accurate test. Treatment is now Paget's disease gives high output cardiac congestive heart failure. Treatment is as follows. For asymptomatic disease, no treatment needed. When there is pain, bisphosphonates. When there is bone pain and NSAIDs are failed, calcitonin. Adverse effects of therapy modalities for Paget's disease of bone are as follows. Adverse effects: bisphosphonates, jaw necrosis, flu-like symptoms, and esophagitis. For non-pumping repairs, low calcium, low magnesium, low iron, low B12, calcium difficile, and pneumonia. Octreotide or lanreotide, gallstones and cholecystitis. Cabergoline, heart valve disease. Adrenal disorders. Figure 2.1 Pituitary adrenal axis. Pituitary gland, hypothalamus, CRH, cortisol-releasing hormone, and, and pituitary gland releases ACTH. Adrenal, two adrenal glands secrete cortisol. Hypercortisolism. Cushing syndrome can be used interchangeably with the term hypercortisolism. Cushing disease is a term used for the pituitary overproduction of ACTH. Hypercortisolism can also be from the ectopic production of ACTH from carotenoid or cancer or from overproduction autonomously in the adrenal gland. Prednisone and other glucocorticoid use can cause the same manifestation. Etiology of hypercortisolism. Cause of hypercortisolism and frequency. Pituitary ACTH greater 70%, adrenal 15%, unknown source of ACTH 5%, ectopic ACTH cancer or carotenoid 10%. Presentation includes fat redistribution, bone paste, truncal obesity, buffalo hump, thin extremities, and increase abdominal fat, skin striae, erupting, decreased wound healing, and thinning of skin, osteoporosis, hypertension from increased sodium resorption in the kidney and increased vascular reactivity, menstrual disorders in women, erectile dysfunction in men, cognitive disturbance from decreased concentration to psychosis, polyuria from hyperglycemia and increased pre-water clearance. Diagnostic testing focuses on establishing the presence of hypercortisolism and then identifying the cause of the hypercortisolism. One establishes the presence of hypercortisolism. The 24-hour urine cortisol is the best initial test to confirm presence of hypercortisolism. If an elevation occurs, hypercortisolism is confirmed. If urine cortisol is not among the answered choices, choose the 1 mg overnight dexamethasone suppression test, which should suppress morning cortisol. As suppression occurs, hypercortisolism can be excluded. Expect to see some false positives in the presence of depression, alcoholism, and obesity. To establish the cause of hypercortisolism, ACTH testing is the best initial test to determine the cause or location of hypercortisolism. Decreased ACTH means there is an adrenal source. No ACTH level shows adrenal source. Elevated ACTH means one of two possible sources: pituitary source or an ectopic production. Pituitary source suppressed with high dose dexamethasone. 1. ACTH is elevated and suppressed with high dose dexamethasone. 2. An MRI to scan the brain. If no clear pituitary lesion is seen, sample the inferior pectoral sinus for ACTH, possibly after stimulating the patient with corticotropin-releasing hormone (CRH). Elevated ACTH from the venous drain of the pituitary confirms the pituitary as the source. The pectoral venous sinus must be sampled because some pituitary lesions are too small to be detected on MRI. Ectopic production does not suppress with high dose dexamethasone. If the ACTH is elevated, you cannot find a defect in the pituitary either with MRI or pectoral sinus sampling. Do a chest scan looking for an ectopic source of ACTH production, example lung cancer, carotid tumor. You must always confirm a source of hypercortisolism with biochemical tests before you perform imaging studies. ACTH high dose dexamethasone test, suppression, pituitary, low suppression, ectopic or cancer. Cortisol is also a stress hormone. It has an anti-insulin and an aldosterone-like effect on kidneys distribute of excreting potassium and hydrogen ions. It causes the following: hyperglycemia, hyperlipidemia, hypokalemia, metabolic alkalosis. Leukocytosis from demargination of WBCs. At least 50% of WBCs in the blood or on the vessel wall wait for acute stress to come into circulation. They are like parked police cars waiting to be called. Non-midnight salivary cortisol test excludes hypercortisolism. Tier 2.2 Hypercortisolism Diagnostic Evaluation Part 1. Chief complaint: I feel weak and tired, and I notice hair growth on my face and strange marks on my stomach. 1 mg dexamethasone suppression test. Decrease, disease excluded. Cortisol testing: 24-hour urine, late night salivary cortisol increase, same ACTH level testing. If high, then pituitary or ectopic cause. If low, then adrenal cause. Tip: at least 10% of the population has an abnormality of the pituitary on MRI. If you start with a scan, you may remove the pituitary when the source is in the adrenals. Treatment is surgical removal of the source of the hypercortisolism. Transperineal surgery for pituitary sources, laparoscopic surgery for adrenal sources, pasireotide supranuclear NDOC if surgery is not successful. Mifepristone, which inhibits cortisol receptors throughout the body if surgery is not possible. If adrenal cancer cannot be fully resected or there is metastatic disease that cannot be identified, give metolidine, an inhibitor of steroidogenesis that is also cytotoxic to adrenal tissue. Pasireotide controls unresectable pituitary ACTH overproduction. Mitotane cleans up adrenal cancer myths. Tier 2.3 Adrenal masses. Adrenal masses. How far should you go in the elevation of an unexpected asymptomatic adrenal lesion found on CT? Metapnephrines of blood or urine to exclude pheochromocytoma. Do these first, because operating on a pheochromocytoma without proper pre-medication such as phenoxypenzamine alpha blocker is dangerous. Renin and aldosterone levels to exclude hyperaldosteronism. 1 mg overnight dexamethasone suppression test. 4% of population has adrenal angioplasma. Do not start with a scan or you will remove the wrong organ. Period of incidental adrenal masses. Favoring benign status, size less than 4 cm, low density less than 10 pounds per unit, and high/rapid contrast washout. Appeal from malignancy, size greater than 4 cm, high density greater than 10 Hounsfield units, low/slow contrast washout, rapid state rate of growth greater than 1 cm per year. Figure 2.4 Hypercortisolism Diagnostic Evaluation Part 2 ACTH Dependent Cushing Syndrome Pituitary versus ectopic ACTH production High dose dexamethasone suppression test Suppression of cortisol Pituitary normal Cushing disease If increased ACTH and cortisol okay. Suppression of cortisol in pituitary normal Cushing disease Pituitary mass then do pituitary MRI no mass seen petrol sinus sampling for ACTH high dose dexamethasone suppression test if we do increase ACTH and cortisol then ectopic ACTH screening tumor and we do a chest CT. ACTH independent Cushing syndrome adrenal mass for that 2 CT adrenals. Confirmatory laboratory findings in adrenal disorders. Adrenal pituitary ectopic ACTH level is low in the adrenal gland. Petrol signs are not done and high dose dexamethasone shows no suppression. In pituitary lesions, ACTH level is high. Petrol signs high ACTH. High dexamethasone dose dexamethasone suppresses ACTH. Ectopic ACTH level is high. Petrol signs low ACTH and the high dose dexamethasone no suppression.